she has been, she has received IV fluid like.
You're the nephrologist of the hospital. She's not received anything so far. You're the one to decide. Okay, so fair enough. So you decided patient is hypovolemic. You gave a fluid challenge, but there is no urine output. What would be your next step in evaluating this patient? What will you do next? There's no urine output. The BP is holding at say 180, but there is no urine despite your fluid challenge, your IVC collapsibility you have taken care of. What next?
Furosemide challenge test can be done. Right? If the patient volume status has improved after correcting the hypovolemia, if still patient is having decreased urine output.
So how much what do you understand by furosemide challenge test?
It's mainly to test the integrity of the tubules. We give furosemide 1 to 1.5 mg per kg intravenously, and then we look for the urine output. After 2 hours, if the urine output is more than 200 ml after 2 hours, then it's actually a positive test, and it suggests that the tubules are functioning, and there is chance that patient may recover without the need for dialysis, progressing to renal.
All right. So this patient, however, became anuric within 24 hours in that hospital there and became nil. So can you tell me how often does a garden variety of ischemic ATN become completely anuric? Is it common, uncommon?
Uncommon, sir.
So if you have somebody who is absolutely anuric in the setting of acute kidney injury, what could be the possible etiology?
First thing is obstruction. We have to rule out obstruction, bilateral ureteric obstructions, secondary to ureteric stones.
What can cause bilateral ureteric obstruction?
Presence of ureteric calculi, sir, bilateral. So,
or is a single functioning kidney and
single functioning kidney with the opposite side calculi, or bladder outlet obstructions.
Other than this,
then acute cortical necrosis can also present with anuric AK, sir. Secondary to TMA or and then glomerular causes, sir, like crescent glomerulonephritis. They can also present with the AK with the anuria, sir.
Transplant scenario, if suddenly somebody becomes anuric, what would you think of?
Rejection, we have to think, sir. Antibody mediated.
Rejection won't come with sudden onset of anuria. More likely a vascular, something like that.
Yes.
Okay. All right. So from whatever you have presented now, what do you think is before you go on to the examination, what do you think is your opinion about this patient with the available data? Don't be influenced by what you're going to present later. With the available data, tell me what is your provisional working diagnosis here?
So my working diagnosis at this stage is acute kidney injury, sir. Anuric or oligoanuric, and probable etiology being sepsis, sir. Sepsis and hypotension.
Okay.
And cause for sepsis
cause for sepsis probably some
tropical fever, dengue, malaria. That also.
I think we can give him investigations now, Jay.
Yes, sir. Yes, sir. Let's go on to continue the presentation.
So the findings on arrival at our institute at day 5 of illness, patient was afebrile, but she was sick looking. She had a weight of 60.8 kg, moderately nourished, pulse rate of 98 beats per minute, regular in rate, rhythm, low volume, blood pressure 100 by 60 millimeter of mercury, right arm supine position, on noradrenaline infusion, saturation of 88% on room air. She was tachypnic with respiratory rate of 30 per minute, and head-to-toe examination, she had pallor, bilateral pitting pedal edema, and right IJV catheter was in place. Facial puffiness was present. There was no icterus cyanosis, clubbing lymphadenum. There were no skin rashes like purpura, petechiae, and oral cavity was normal. Systemic examination, respiratory system, bilateral normal vesicular breath sounds were heard. with fine inspiratory basal crackles. Cardiovascular system S1, S2 were heard, and there were no added sounds, murmurs, or pericardial rub. Per abdomen, soft, non-tender, no organomegaly, no free fluid. CNS examination, she was conscious oriented, and there were no focal neurological deficits, and the fundus was normal.
So at the end of examination, is there anything else? Let's go back to the previous slide. At the end of examination, does it change your differential diagnosis, or differential diagnosis remains the same?
No, sir, it
What were
remains.
the positive findings you found on examination?
Yes, sir.
Patient
Examination.
hypotensive and patient is probably fluid overloaded. There's
Yes, sir.
not too much difference to your differential.
Patient was.
Okay, you can go on. Present the hematology.
So the initial investigations at our hospital, so hematological parameters showed anemia, significant anemia. Hemoglobin was 8 gram per deciliter with the leukocytosis, polymorphonuclear leukocytosis with severe thrombocytopenia, platelet count being 20,000 cells per cubic millimeter. And peripheral smear showed normocytic normochromic anemia with leukocytosis, thrombocytopenia, and cystocytes of 2%. No hemoparasites were seen. Haptoglobin levels were reduced, less than 15 milligram per deciliter. LDH was significantly elevated, 2,522 units per liter. PT-INR APTT was within the normal range, and the Coombs test was negative. So biochemical parameters. There was a severe renal dysfunction with the urea being 97 and creatinine 4.3. Electrolytes were within the normal range. She had a significant hypoalbuminemia with serum albumin being 2.2 gram per deciliter. And there was a minor elevation of the liver enzymes also. If the ALT being 51 and 82, and calcium phosphorus being normal in the normal range, corrected calcium being
okay, so the end of
8.6.
hematology and right. So the end of hematology and biochemical parameters. So are you any wiser, or is it all the same?
So at the
previous slide, please. Go to the previous slide. Fair enough. Is the cause of anemia here as per whatever you presented?
So there is evidence of hemolysis, sir, based on the hematological parameters what we have seen. Decreased haptoglobin in elevated LDH and peripheral smear showing cystocytes. So all this suggestive of hemolysis, intravascular hemolysis.
Is it intravascular or extravascular?
Intravascular hemolysis, sir, since the haptoglobin level is reduced.
Why do you say so?
Usually haptoglobulins levels are reduced in intravascular hemolysis.
What are the causes of schistocytes you know of? What are if you see schistocytes in peripheral smear, what could be the various causes?
Cystocytes are mainly microangiopathic hemolytic anemia, sir. Thrombotic microangiopathies, HUS, TTP.
There are schistocytes. The only diagnosis possible is microangiopathic hemolytic anemia, or there are other reasons also for having schistocytes in the peripheral smear.
Even in patients with severe burn injuries, they can also have cystocytes in peripheral smear.
What else?
Even macroangiopathic, no, sir.
Suppose there is a mechanical valve.
Mechanical valves, even in the presence of prosthetic valves, mechanical valves.
You have
then
a
also
calcified aortic valve.
yes, sir.
Wherever RBCs are getting
RBCs
scared, you will have it. In microangiopathy, the pathology is microangiopathy, capillaries. You can have it in large vessels also.
Large vessels.
Any other cause you are aware of? Scleroderma, renal crisis, you may have schistocytes, and so many other causes are there.
Malignant hypertension.
So I say that suppose patient has sepsis and DIC, can you have schistocytes or you cannot have schistocytes?
Sepsis with DIC, sir.
Does this picture suggest DIC, Sooraj?
No, sir. Since the
Just a dental.
PTINR APTT is within normal range, coagulogram. So in DIC, it will be usually Diarrhea, sir. So
Just for semantic, when do you say schistocytes are present? What percentage should be positive?
at least more than 2%, sir.
1 or 2%?
Yes, sir.
I thought maybe 1%.
More than 1%, you
1%.
can. Yeah.
And what is the other name of schistocytes?
Helmet cells.
Okay. Okay. So this patient has schistocytes.
Yes, sir.
That's all right. But you said that the APTT is not abnormal,
Yes,
which
sir.
is going against a DIC.
Yeah.
Right? Can you come to the next slide? Achha, this is, yeah, nothing great. That the bilirubin is elevated, ALT is mildly elevated, a feature of intravascular hemolysis. Next one. Yeah. What is the positive thing here?
Here,
Is elevated.
yes, sir. Serum procalcitonin significantly elevated, more than 200 nanogram per ml. Whereas other workup for tropical fever like dengue, serology, IgM leptospira, scrub, Vidal, wheel felix were all found to be negatives. And with blood culture being sterile and stool culture did not grow Vibrio, Salmonella, Shigella. And even stool for toxins, which was tested by PCR, was found to be negative for Shiga toxin 1, 2, and E. coli 157S.
Okay.
So what do you think, based on whatever infection workup you have done, what do you think is the cause of this entire patient's presentation and renal syndrome here?
So in this patient, the microangiopathic hemolytic anemia has to be considered, sir, since there is significant evidence of hemolysis with presence of cystocytes in the peripheral smear. But coagulogram being normal, so DIC is unlikely. But she's having some element of sepsis because procalcitonin is significantly elevated, more than 200 nanogram per ml. So, however, the routine workup for tropical fever and even cultures were negative.
Just one question, Sooraj.
Yes.
Are cystocytes a must to diagnose MAHA?
At least 1 to 2% cystocytes has to be present in the peripherals.
Yes. Of course, there are no guidelines don't say that cystocytes need not be present, but cystocytes is something which is reported by a pathologist.
Pathologist.
If you have other evidence of microangiopathy, like raised LDH, raised LDH or a haptoglobin low, then you, and probably initially your it may be missed, or so your, if you have other features, other objective evidence of MAHA, you're not going to withhold treatment just because your pathologist has not reported cystocytes. Yeah, go on.
Okay, go on. Go to the next slide.
Next. So, radiological investigations, chest X-ray showed blunting of the left costophrenic angle with no evidence of pulmonary edema. And ultrasound showed normal sized kidneys, right kidney 9 centimeter, left kidney 9.2 centimeter, with the CMD being maintained. Immunological workup, the complement C3 and C4, C3 being on the lower side, 84, and C4 being normal, 11.6. ANA ANCA was negative, tested by immunofluorescence, and ADAM TS13 activity was also 45.7%.
What is the diagnosis now?
So
the whole workup.
Yes, sir. So TTP is kind of ruled out, sir, since the ADAM TS13 activity is 45.7%, usually less than 10% is suggestive of TTP. And C3 being on the lower side, so complement mediated HUS can be considered, sir.
HUS, yes, because whatever criteria you have got,
Yes, sir. Hemolyte.
patient has evidence of hemolysis,
Yes, sir.
patient has acute renal failure, right? Patient has low platelet count. So he is fulfilling the criteria
Right.
to be called a patient of HUS. But at the same time, you said that TLC is 58 or 48,000.
Yes, sir.
Procal is 200.
200.
So there is some infection
And
agent,
sepsis. Yes.
some bacterial infection is there,
Yes, sir.
which it has not been
Not
picked.
been detected.
Infection is there.
Yes, sir.
We don't know whether this infection has precipitated
And,
HUS. Is that a possibility?
yes, sir. Possibility is there.
Okay. Okay.
Usually atypical HUS usually precipitated by infections.
Which infections can precipitate atypical HUS?
Usually gastrointestinal infections, diarrhea.
Mm-hmm.
This looks more like a bacterial infection.
Yeah.
Bacterial.
Which are the bacterial infections which can cause? I mean, nowadays, instead of using the word atypical, you say complement mediated.
Complement mediated.
So which bacterial infections can cause?
E. coli.
Shiga toxin producing E. coli.
Shiga toxin producing E. coli. Then pneumococcal. Pneumococcus.
Yes.
Streptococcus pneumoniae, yes.
Streptococcus pneumoniae. Then Shigella dysentery, but the incidence has reduced.
There was no dysentery, you said.
No, there was no history of any dysentery.
Yeah.
Any bacterial infection, if there's an underlying complement
Defect
can unmask a complement defect. That is a possibility which you cannot rule out here, but you haven't done all the tests so far to demonstrate that. Go on further. Oh, sorry, you want to ask something, madam?
No.
Okay, so let's proceed.
No, go ahead.
We have already done 35 minutes. Yeah, go on.
So the course in the hospital, initially she required oxygen support of 4 to 5 liters per day. And she received 3 consecutive sessions of slow low efficiency dialysis in view of anuria and volume overload. And underwent 2 sessions of plasma exchange prior to renal biopsy. She received antibiotics, meropenem and doxycycline for a period of 2 weeks and 10 days. And by day 8 of illness, her BP had improved to 130 by 80 millimeter of mercury. She was afebrile and saturation had improved to 98% on room air. However, HD was continued in view of persistent anuria and she was having volume overload. And she also received 3-unit PRBC during 3 sessions of HD. So biopsy, which was done on date 12 of the illness. So biopsy, this under low magnification, it mainly shows ghost outline of the glomeruli and the tubules with the areas of necrosis, patchy necrosis involving majority of the parenchyma. This is under high power, the similar findings where we can see the ghost outline of the glomeruli and the tubules with the necrosis. So this is the pH stain showing the viable glomeruli with the ischemic wrinkling of the glomerular basement membrane. However, there is no evidence of any mesangiolisis or the fibrin thrombi, and the tubular epithelial cells show the presence, tubules show granular cast and epithelial cell dropout. And so this slide, it mainly shows interlobular arteries with thrombosis with the denuded endothelial cells, and again the tubules showing the presence of granular cast. And this is the silver staining, which again shows similar findings, which was seen in the PST. And the immunofluorescence report, it was negative for immunoglobulin GAM, C3, C1Q, kappa, and lambda. So the impression was acute cortical necrosis involving 50% of the parenchyma, secondary to vascular thrombotic microangiopathy. So the course of
here one question I would like. So here predominantly it is a glomerular thrombi, right? Because you have a cortical necrosis on histology.
Yes.
Although the histology doesn't differentiate the, doesn't specify the etiology, is there any difference between the etiology when it comes to glomerular thrombi more common or arteriolar thrombi more common?
Ma'am, if I may interrupt here, I think none of the glomeruli showed thrombi. They just showed ischemic wrinkling. The thrombi were outside the glomeruli.
Oh, okay.
Suraj, would you please show the slide again, please?
Interlobular arteries showed.
Thrombi are in the glomerular arteries. The glomeruli did not show any thrombi. But you may still answer the question.
That is what Anuradha ma'am is asking. Can you make some etiological difference if the thrombi exist within the glomeruli versus
glomeruli? There was no evidence of thrombi.
Okay, so arteriolar thrombi.
Arteriolar
thrombi. And the glomeruli are showing ischemic changes.
Ischemic changes.
In which
what
condition
ma'am is asking
you
is
get predominantly arteriolar thrombi?
So let me make it easier for you. So if it's Shiga toxin or if it is diarrhea associated,
predominantly involves the glomeruli. In case of Shiga toxin mediated, this typical HUS.
In a complement mediated, you get more involvement of glomeruli.
Glomeruli.
But in this arteriolar thrombi, which conditions are more likely to cause arteriolar thrombi?
Malignant hypertension.
Good.
Yes.
Sclerodermal crisis. So,
yeah.
More likely
so
to
these complement associated HUSs generally cause the thrombi outside and they cause ischemic wrinkling of the glomeruli.
Glomerular basement. Yes.
Yeah.
Go on.
So the course of investigations during the hospital stay. So as I told, she had...
Sooraj, can you wait for a minute? If you were in the best center in the world, what would you have done differently than what was done here?
Can you go 4 slides back? That will be easier.
So when you first saw this patient in your hospital and you found that this was microangiopathy, so what would you have done if you were, everything was available to you, everything was given to you? What would you have done?
Go back 2 slides. Go back. Go back. Written material. Yeah, just before this.
Before the biopsy.
Before the biopsy. Yeah, you said line 3. He underwent 2 sessions of plex prior to renal biopsy.
Yes, sir.
So now the question given to you is, if you had all the facilities, what would have you done?
The eculizumab.
So when would you use eculizumab in a patient with AHUS or complement mediated or whatever?
Within 24 to 48 hours, it should be started.
As soon as you make a diagnosis. So diagnosis of AHUS is a clinical diagnosis. You don't require a you don't require a biopsy or anything to do. And to prevent what has happened to this patient, you would want to give it the moment you make a diagnosis that this is hemolytic uremic syndrome, then you would want. The only drug which seems to help in these patients, and even in patients with Shiga toxin, and as was being talked about earlier, that many infections also unmask a inherent complement deficiency in some patients, which is not uncommon in the general population. So some unmasking by an infection or a trigger and a second hit probably occurring because of infection, and you get these kind of syndromes. And the only way you can prevent this would be by using eculizumab. The only problem is that in our country it's not easily available. The costs are prohibitory, and therefore, and to prevent what has happened in this patient, unfortunately, Plex may help in some patients, but usually is not as good. Eculizumab would be the drug of choice in such patients. Yes. Okay. You can go ahead now.
Yes. So the investigations.
Just go back one slide back. You have not, yeah. When what was that? Yeah.
Yes, sir. The course of the investigations during her hospital stay, sir. So we see that at the time of admission, HB was around 8 gram per deciliter. So it had a falling and rising trend. So we had to give around 3 unit PRBC during the hemodialysis. She received around 6 sessions of hemodialysis, sir, and around 3 unit PRBC during the 3 sessions of dialysis. The counts we see at the time of admission, it was 56,000, significantly improved, sir, by the time she discharged. And the platelet count also had improved. And by the time we biopsied after 2 sessions of Plex, it had increased to 2 lakh. And other parameters like creatinine, however, by the time we stopped HD and she was discharged, it was around 4 to 5 milligram per deciliter. And LDH showed a decreasing trend from 2,500 to it had reduced to 340 by day 17 in a gap of 10 to 12 days. And even procalcitonin also had significantly reduced from more than 200 to 27 by the time we biopsy.
So, Sooraj, if I may ask you here.
Yes, sir.
To continue with the question that Dr. Kher had asked, do you think this patient responded to Plex?
Yes, sir, because there was improvement in the platelet count.
What are the criteria? What are the parameters? What are the parameters that you are looking for when you start Plex for a patient?
No, I just put it, Ranjith, again. If you look at the first Plex is given when the platelet count has already become 1 lakh.
1 lakh, yes, sir.
Yes, sir.
When the platelet count has already recovered, what was the use of giving Plex?
Sir, my point, I'm coming to just that, sir. That the basic thing is the treatment was started late.
Yes.
This patient was possibly Plex responsive, or maybe it was just coincidence that the Plex was started when the platelets were already recovering and the treatment was over.
Platelets were already up. The recovery had already started before.
But the LDH had also begun to come down.
Yeah.
So I guess there was a delay in the onset of therapy more than anything else. Maybe she would have responded to Plex alone instead of eculizumab.
Yes.
So when this patient presented, patient was hypotensive on inotrope with the procal more than 200. So that time sepsis was the overwhelming presentation.
Yes, the presentation is very unusual.
Antibiotics, get the patient hemodynamically stable before, the treatment will come to, we gave steroid pulses also.
Yes, steroid pulses.
And that's how the platelet count came up possibly, I don't know. And then Plex was initiated. In the buying time, we were trying to get eculizumab in the process for this patient through the scheme which the patient was covered for. So one may use Plex as a bridge therapy till logistics allow you to procure eculizumab, since probably no hospital in India is going to stock eculizumab to be used within 24 to 48 hours. It's pure logistics, that's all.
Yes.
Go on, Sooraj.
Next. So the treatment received, she received 4 sessions of Plex between day 9 to 15 of illness. And she had received a methylprednisolone pulse, 1000 mg, 500 mg, 250 mg, and followed by oral steroids, which were rapidly tapered over a period of 2 weeks, and underwent renal biopsy on day 12 and received further 2 more sessions of Plex. And as Sir told, she was planned for injection eculizumab, but it could not be procured because of financial and logistic reasons. By day 17, her urine output started improving, and by day 19, dialysis was discontinued, and her urine output was more than 1 liter per day, but the serum creatinine was between 4 to 5 milligram per deciliter. And we had sent for genetic workup. to look for the complement-mediated abnormalities, which was done by next-generation sequencing, which did not identify any pathogenic variant in relation to the phenotype, like the complement factor H related proteins 1, 2, 3, 4, 5, factor I, MCP, DGKE, thrombomedulin, all these genes were looked for, but no pathogenic variant were identified.
Suraj, is it common?
One more question here.
Is it common to have no?
The genetic workup you for on so many genes you've identified,
Yes.
but if you're thinking this is immune mediated, I mean,
Yes.
if it is immune mediated, did you look for antibodies to complement factor H?
So I'd like to answer that, madam. This patient unfortunately was covered with a scheme where anything done in the hospital is allowed, not a rupee outside the hospital. So this gene was a squeeze for us to make the patient pay nearly 20,000, and the patient was unwilling to spend any money outside the hospital. Whatever was available within the hospital resources was covered with the scheme. Patient was from the slightly low socioeconomic strata. So we could not do the anti-factor H antibody, though it is highly desirable.
Because now the diagnosis, whether it is genetic or immune mediated, you need to differentiate. So if the genetic,
completely point taken.
Yeah, so probably that would have. And the other thing is, since this patient biopsy is showing a cortical necrosis, as part of an immune workup, I think you should also have sent for APLA, because catastrophic APLA, although renal limited disease in APLA is rare, but seeing the way she has progressed,
yeah, so
probably a catastrophic could have been done. Maybe.
So just a question: is it common or it is uncommon to find no abnormality in the complement? You have done.
You'd like to answer that, yeah.
So didn't get your question.
No, you said you did the genetic workup and there was no abnormality found.
Yes, sir.
Is it common to have such finding? No abnormality?
Yes, sir. You can have, because there may be mutations which have still not been detected, which can contribute to the atypical HS, as well as MLPA should can detect the copy number variants, sir, in CFHR. So that was not done. It was mainly next generation sequencing. So
yeah,
possibility is still there.
30% of the patients you may not find that.
Yes.
Okay.
So coming to final diagnosis, my syndrome will be acute kidney injury, oliguric, KD stage 3, and she was recovering by the time of discharge. And etiology being sepsis and vascular thrombotic microangiopathy, probably complement genetic abnormality. She was discharged on day 22, about 3 weeks after the onset of symptoms. And by the time she was discharged, her urine output had improved to more than 1 liter per day.
I think maybe General Verma, we should now ask Dr. Ranjith to probably, and then we can have further discussion maybe
after that.
After that, yeah.
Thank you, sir.
Dr. Ranjith, you can go ahead.
Sir, are my slides visible, sir?
Yeah,
yes,
please. Absolutely.
So, to the audience, I don't think TMA needs any introduction. It's a classical triad of thrombocytopenia, microangiopathic hemolytic anemia, and organ dysfunction. Usually renal, which comes to us, but you can also have gastrointestinal and neurological. I would not be hanging too long upon normal vascular patency, but we know that there's a very fine balance between the pro and anticoagulant factors, and the virtuous triad is extremely important to maintain normal blood flow. And endothelial patency, endothelial intactness is a very important part of the coagulation. It's a very busy slide, but this basically tells you the way coagulation factors and the cascade works. So you have platelet activation, which leads to the primary hemostasis, which is primary plug, and the secondary hemostasis through the coagulation cascade, either because of collagen injury, which leads to exposure of the tissue factor, cross-linked fibrin, and the clot. And when there is fibrinolysis, when there is plasmin that is released, the prothrombosis and antithrombosis are commonly occurring at a constant rate. The TMA, as far as when you look at the pathophysiology of TMA, the triggers of vascular injury, as we have already discussed, could be infections, it could be immune complexes, drugs, pregnancy, and malignancy. There are predisposing factors like genetic deficiencies, complement activation, abnormal ADAM TS, inadequate ADAM TS, and of course, paroxysmal nocturnal hemoglobinuria. It leads to loss of the endothelial thromboresistance, leukocyte adhesion, complement consumption. This leads to enhanced vascular shear stress and abnormal von Willebrand fracture fragmentation, which ultimately leads to systemic thrombotic microangiopathy, which is what leads to the clinical signs and symptoms. This is the coagulation pathway, and we know that there is a classical pathway, which is activated by immune complexes, and the mannose binding lectin pathway, which is activated by bacteria. And this is the one we are referring to where infections can precipitate the coagulation cascade. And we have the amplification loop, which occurs through the alternate pathway, and various complement amplifiers exist. Factor H and factor I are the inhibitors of this alternative pathway, and they prevent persistent activation of C3b. It's a very busy slide just to understand that there is a crosstalk between the complement system and the coagulation cascade, where the thrombin, the platelet activation, the plasmin, the kallikrein, the FSAP, the tissue factor, all these lead to activation of C3 and C5, which ultimately lead to inflammation. They are supposed to kill the bacteria, but they also cause coagulation. Coming to the diarrhea-associated HUS, usually it is Shiga toxin or the E. coli O157H7, which was the commonest one. It's sporadic in 5% of cases and about 20% in epidemics. It's usually from cattle and contaminated food and water. Bloody diarrhea, Shigella is usually a dysentery. CNS involvement is seen in about 20%, but leukocytosis is a hallmark. Epidemics are generally seen in children and the elderly. There have been outbreaks across the world, whether it's the US or UK or Germany. The last one we read about was in Germany, where 855 children were affected and there were 52 deaths, and it was ultimately localized to beef that was served in some of the burgers that they ate. There is a Indian data from Dr. Srivastava in 1991, where 73 patients had Shigella in 7 cases and E. coli in 11, and in the others they could not diagnose, but there was 60% mortality, and cortical necrosis was seen in 20 out of 50 biopsies that were carried out. Coming to the atypical HUS, about 60% of patients have identifiable mutations of the alternative pathway. So to answer the question that ma'am had asked, we may not find what are the known mutations in more than 40% of cases. There are loss of function mutations, which could be the MCP, the complement factor I, or the complement factor H, or antibodies to the complement factor H. And then you have active or gain of function mutations, which are C3 mutations, or the complement factor B mutations, which lead to the super B, which is resistant to decay. Ultimately, they all cause injury to the endothelium, expose the subendothelial matrix, and lead to coagulation. In about 12% of cases, combined mutations may be seen. Though atypical HUS is discussed a lot, it's not very common as a cause of HUS and usually not preceded by typical infectious causes. It can affect all ages, but the larger chunk is adults. And we have to exclude other causes of TM. So the mutation plus a polymorphism, which requires a triggering event, which is why these people go on till adulthood. The triggering event is probably missing, and that leads to the atypical HUS. The commonest cause, of course, is mutations in the complement factor H. The morbidity and mortality is also highest because of it, but they are usually seen in children. When you come to the older one, anti-complement factor H antibodies are the ones that are seen. Relapse risk is highest in patients with the membrane cofactor protein mutations. Next comes anti-complement factor H and complement factor H mutation. And of course, transplant recurrence is highest in these complement factor H and I mutations. But plasma therapy this is of course a very old slide, but plasma therapy is indicated in all of them except possibly membrane cofactor protein mutations. Then you have drugs. This is something which was not discussed very much here. Drugs could cause thrombosis, intravascular thrombosis, either by damaging the endothelium directly, like fluorouracil or cisplatin, causing morphological changes in the platelet membranes, which increase their aggregability, like neuroleptics, or changes in thrombogenic substances, like increasing phospholipid antibodies or reducing the inhibitors, like antipsychotics and L-asparaginase, or vasoconstriction, which could be caused by drugs like cisplatin. They could cause immune-mediated damage because of antibodies or direct toxicity to the vasculature in the form of CNIs, VEGF inhibitors. These are drugs that are more and more commonly being used in increasing indications today. CNIs is something we as nephrologists use very often, which is why I've kept a separate slide for it. Cyclosporin is, in literature, cyclosporin is known to have caused TMA much more than tacrolimus, and basically enhanced von Willebrand factor released from cultured human endothelial cells was considered to be a cause. The common mode of injury is direct endothelial injury. And it was, now we don't see it very much because apparently in those earlier days in the 90s and the early 2000s, the dose of cyclosporin that we used to use in our transplant patients used to be very high. And it may occur in the overt absence of microangiopathic hemolytic anemia. And it could even occur in patients, it could precede or follow renal dysfunction. Pregnancy-associated TMA. One possibility was a young woman who had a pregnancy which was wasted and she was not aware of. However, if you see, all these conditions of preeclampsia, acute fatty liver, help all occur after 20 weeks. While there is a entity known as postpartum HUS, which is not related to all of this, but again, it is a complement or an immune complex mediated HUS. So the diagnostic algorithm would be the classic triad: take history to rule out drugs, ensure there is no autoimmune hemolysis, look at the coagulation profile. If all is normal, exclude secondary causes, especially autoimmune causes. Recommended levels of investigation. At the level 1, ADAM-TS should be done, transaminases, the complement panel, blood smear, bilirubin. All these have been done for this patient. ANA and Shiga toxin, PCR. Everything has been done. The level 2, all the complement mediated, the mutations and deletions have been looked for. This, of course, has not been done. And as asked very rightly, was the complement antibody done? That was not done. They have gone ahead and done even the level 3, where ADAM-TS levels have been proven to be more than 40%. And of course, the DGKE mutation, if the presentation is less than 2 years of age, and hence that was not done. Kidney biopsy was done. So I would compliment the treating team for having done every possible step that could have been done for this patient. We sometimes get the diagnosis, sometimes we don't. ADAM-TS analysis, of course, if it is less than 30%, then an inhibitor screen is to be performed. And typically the autoantibody inhibitors have been reported in idiopathic TTP, which is IgG. And it is always ideal to send it before the flex or the transfusion is started. In congenital TTP, which are seen in children, the antigen activity is very low, while in acquired TTP, it is variable. Other TMAs, it is elevated, which is probably where our patient fits in. The differential diagnosis has already been discussed. Malignant hypertension, which was not the case here. The lady was never diagnosed to be hypertensive. She was never pregnant. The ultrasound would have checked it out otherwise. Was there sepsis? Yes, there was leukocytosis. There was elevated procalcitonin. But as has been rightly pointed out by Dr. N.P. Singh in the chat question and answers, there are other non-infectious causes of elevated procalcitonin. We could look at those too. Autoimmune diseases, we have done the ANA, which is negative. And of course, hemorrhagic fever, which could be seen from clinical profile, which she didn't have. If you look at the onset of renal failure, this is a sort of rough rule of thumb. that if there is minimal or no kidney injury, TTP is a possibility because it is supposed to cause greater neurological signs. If there is very sudden and severe kidney injury, think of a drug. And if it's over days, like what has happened in this lady, 2 to 5 days, think of complement mediated or toxin associated TMAs. And if it occurs over days to weeks, think of chemotherapeutic drugs. Immediate plex, of course, this is much before what eculizumab was available, and even now it's not freely, of course, available, but an immediate plex was possibly what could have been done for this lady. There are, of course, benefits and risks, and we need to use plasma and factor VIII concentrate as replacement. Anti-complement therapy, I will come to the indications for that, is to prevent irreversible renal injury. Unfortunately, it has already occurred in this lady, and only if you are certain. I guess this has been put in because the drug is very expensive. And of course, we must exclude offending drugs, consider immunosuppression and transfusion. So when you look at plasma therapy is usually inefficient. If you diagnose TMA and you need to start treatment emergently, then we have to do daily plasma exchanges for the first 3 to 5 days. And each plasma exchange must have 1.5 times of plasma volume exchanged. Once you see a decline in the LDH, a rise in the platelets, and hopefully an increase in urine output or a decline in creatinine, is when you can switch it to alternate days. If the patient responds to standard therapy, you can progressively decrease your plasma exchange over 3 to 5 weeks. If your ADAM-TS is low, then you look at TTP as a diagnosis and manage it appropriately. If you have managed to not get an optimal response, you're looking at refractoriness or even worse, exacerbation of the disease, then you please consider anti-complement compounds. This is the current algorithm. This is again from Nature Reviews on use of eculizumab, where it clearly says the first episode of HUS in children, if it is Shiga toxin, pneumococci, or methylmalonic acid, consider specific management. If you've got atypical HUS, where there are clearly defined complement activation or inactivation, or MCP expression or anti-CFH antibody, the first line should be eculizumab. Unfortunately, by the time you get these diagnoses, these investigations done in our country, it's already 4 or 5 days. In an adult, of course, all this has been done for this patient. I would not remember seeing the HIV serology. Sooraj, was that done? I'm sure
yes.
Before dialysis.
Yeah. Yes.
Negative. So if your ADAM-TS is deficient, or you are suspecting HIV, neoplasia, systemic disease-related HUS, first line of therapy, plasma exchange. Uncertain diagnosis, like in this case, possibly it was uncertain, and you are still waiting for these complement factors, daily plasma exchange. If there is resistance, switch to eculizumab. If there is dependence on plasma therapy, again switch to eculizumab. If you have unequivocal diagnosis of atypical HUS, consider eculizumab as a first-line therapy. And in a post-transplant recurrence of atypical HUS, always consider eculizumab as a first-line therapy. The UK consensus, of course, it's from the British Journal of Hematology. When you have an acute microangiopathic hemolytic anemia and thrombocytopenia, if it is STEC-associated HUS, treatment is very specific. If it is acute TMA, TTP, or acute atypical HUS, acute renal failure, ADAM-TS is low, replace ADAM-TS. If it is elevated, atypical HUS, eculizumab, and if it's TTP, immunosuppressive therapy. And of course, as I mentioned, samples have to be taken for ADAM-TS before a plasma exchange. So plasma pheresis, when do we start? As soon as possible, preferably within 24 hours. 1.5 times plasma volume with FFP for restitution, daily, then 5 per week for 2 weeks, and thrice weekly for 2 weeks. When to taper? Normalization of platelets, cessation of hemolysis, improvement of renal function. What do you monitor? Neurological symptoms should resolve within 3 days. LDH should come down by day 5, thrombocytopenia in another 10 days, and the renal function should improve in 15 days. Eculizumab in atypical HUS, after 3 to 5 daily plex, by then we hope that all the other investigations are in. If not, bile on plasma exchange, you're tapering and it relapses. Patient is unable to tolerate plasma exchange. Vascular access being difficult, I guess that's not so important. Problem is the cost. If you look at the dosing, in the induction phase, every week you have to give 900 milligram, and 300 milligram costs about 70,000. So you're looking at 2.1 lakhs. So, which is about 10 lakhs for the first 1 month. And thereafter, this is going to be 3 lakhs each alternate week. And you carry on till you try and make a clinical, if there's clinical resolution, you could consider tapering it off over time. So the therapy is going to be horribly expensive. This, of course, was the NEJM 2013 article where the eculizumab was used in atypical HUS. And in the long-term improvement of renal function, there was significant time-dependent mean increase in eGFR, significant improvement in proteinuria. Outcomes were similar irrespective of the mutation status. So the first episode of atypical HUS, what should you do? Should you use plasma exchange or eculizumab? In children, first line within 24 hours, basically to avoid plasma exchange or a central catheter. In adults, you need to confirm the diagnosis. What is it? Is it eliminate malignancy, TTP? First P, switch to eculizumab if you find plasma resistance. What is the definition of plasma resistance? There is no constant upward trend of your platelet count. If it continues to be below 150,000, the constant downward trend of LDH is also not obtained, or there is no decrease in serum creatinine despite 5 daily plasma exchanges. If your diagnosis of atypical HUS is unequivocal, there is a family history, it's a relapse, it's a post-transplant recurrence, within 24 hours, eculizumab should be your first line of therapy. This is a short study from AIMS again, where 45 patients, of course, this is much before eculizumab was available, 45 patients with anti-CFH antibody-associated HUS. Following an initial plex, they gave them steroids and cyclophosphamide or rituximab. There was a similar decline in antibody titers with following 3, 5, and 7 plasma exchange session. And the serum CFH antibody titers were similar, whether cyclophosphamide or Ritux were used. Renal outcomes and relapses were comparable. 7 patients relapsed. What about transplantation? This patient is likely to come back. Another question Dr. N.P. Singh has asked is, what about the prognosis of this patient if she has 50% cortical necrosis? Well, cortical necrosis could be patchy, considering that she has produced urine. So this really 50%, you may have gone and sampled a wrong part, a bad part of the kidney. However, if it's actually 50%, her overall outcome over the next few years is not likely to be good. You may require to transplant her. What would you do in such a case? You have already screened her for all mutations. So you have to look at possibilities of STEC, you've done it, it's not there, and MCP associated atypical HUS. Living donation is contraindicated, especially if there is unknown risk in family probands and a high recurrence in the graft. If there is anti-complement factor H antibody as a primary cause, then a renal transplant combined with plex and steroids could be done. And if there is CFH and CFI mutations, there is combined liver kidney transplant to be done. And possibly, if in case of a relapse, a role for eculizumab should be considered. This was the outcome of renal transplantation in 4 patients of anti-complement factor H antibody, again from Dr. Bagga's group in pediatric transplant 2014. They underwent renal transplantation 16 to 62 months from the initial presentation. 2 were diseased and 2 received living kidney donors. All received Ritux, 3 received IVIG and Plex. At 5 to 26 months, there was no recurrence and the graft showed stable function. We know that as far as D plus HUS is concerned, immunosuppression has not really shown any benefit. Neither have antithrombotic agents or heparin. Basically, what we have to remember is antibiotics are known to increase the expression of the toxin from the bacteria which are dying. Anti-motility agents cause greater amount of toxin absorption. Platelet transfusions also do not improve platelet counts. Of course, there is some talk about Shiga toxin binders and certain Shiga monoclonal antibodies. However, they are still at trial phase. I do not have, other than Urotaxazumab, I do not have any other name. I think post-transplant TMA we can leave. So to summarize, when you have TMA, you have to look at atypical HUS and TTP, or sugar toxin associated HUS or secondary. If this is the case, you look at plasma exchange, doesn't work. If an adult, consider eculizumab. Otherwise, if it's sugar toxin associated, supportive care. If it's secondary, take care of the primary disease. So it's a common pathogenic denominator of various conditions, TMA. We need to find out what is the condition which is leading to this. Of course, there has been a dramatic improvement in our understanding of primary TMA syndromes, but there is still a need for specific treatments for a rapid and specific diagnosis so that the treatments can be started in time. There is a great importance of timely and accurate differentiation of acute HUS from acquired TTP and other forms of TMA. And the future areas of studies, of course, will be the optimal length of therapy and patient define time at which the patient may safely discontinue anti-complement therapy after recovery from their acute episode. Thank you, sir. I'm done.
Thank you very much, General Ranjith, for a very exhaustive and lucid discussion. Just few questions from you for clarification. You did mention, of course, this patient had good amount of sepsis. Otherwise, the role of antibiotics in such patients.
Yes. So there is theoretical evidence which shows that antibiotics are been known to increase the amount of sugar toxin released from the dying bacteria, especially cephalosporins.
Yeah. And what percentage of these patients HUS will not have hypertension?
It's an that is the other thing that I forgot to mention. Yes, hypertension is usually an association of TMA-associated kidney injuries. So possibly the
sepsis was the dominant portion.
Yes, yes, there was a dominant.
Was hypotensive. So sepsis was dominant.
Yes, sir.
Will you like to give plasma exchange in this patient on day 9? Then the platelet count is improving.
Good question to ask, sir. I would probably not have given plasmapheresis if the platelet counts had already crossed 1.5 lakhs and the LDH was showing a declining trend.
But possibly on day 3 or day 1, you would have given eculizumab if the complement level was low. Possibly the complement, it had a role there. What is the etiology of cortical necrosis? Just for, because there is a block in the vessels. So whatever the afferent arteriole or the vessels were arterioles before, that is the block. That is the etiology of cortical necrosis. And logically, with this patient with a creatinine of 4.2 or whatever, the eventual outcome is not going to be bright. You feel so?
I feel, sir, we can't really, one, of course, she's been oligoanuric for almost 14 days, if I'm not mistaken. Suraj may correct me if I'm wrong.
Yes, sir. Almost 2 weeks was oligoanuric.
2 weeks.
After that, her output started improving.
Yeah, but unfortunately, she didn't show that typical ATN recovery kind of post-AKI diuresis.
Yes.
Her urine output has gradually climbed up. So I don't think there was too much of an ATN component. Much of it was related to the cortical necrosis only. And the hypotension was contributing.
Before I take comments from Professor K, Professor Jairam, I think very well worked up case, as Ranjith mentioned. Everything possible was done. And short of eculizumab, logically, there is no choice. So your comments first.
So patient presented on the day 5 of illness to us, and that time BP was requiring inotropes or NORAD infusion. So at that point in time, with the TLC 56,000, Procal more than 200, I don't think patient was fit for Plex at that point in time. So, and antibiotics had to be given, notwithstanding the fact that in a diarrheal HUS, it might cause. In a diarrheal HUS, we did not consider at that point any case. So we gave steroids, and after by day 2 of admission with us, when the BP had come up, we are not sure the platelet came up because of the steroids or what. It had come up from 25,000 to nearly touching a lakh. But we gave the benefit of Plex to the lady. And then after that, we did a biopsy. Of course, we could have managed without biopsy. Biopsy was kind of academic too. And it did demonstrate acute cortical necrosis with a vascular TMA. I was just wondering now, post this discussion, if I had eculizumab in my shelf on day one with a patient with a TLC 56,000 with Procal more than 200 on inotropes, would I give eculizumab? Because it is known, we probably did not stress upon it, it can cause severe infections. It's called meningococcal septicemia 500 times more than average population. So it's not a drug which is absolutely safe. Would I give it or not? It's probably a debatable question there. Plasmapheresis, you cannot start in somebody who had infusion. So that is also not possible. So after 48 hours we gave it, I wouldn't blame myself for having delayed treatment. I would say we did the best possible, whatever we have.
Professor Kher, sir.
No,
I would eculizumab also.
Yeah, I would agree with Jairam that he did the best, and I think very commendable kind of complete set of investigations. Ranjith also talked about it, and I think they need to be congratulated, complimented for that kind of thing. But I agree that if one had everything available and all that, now the question is that this patient probably had infection. There's no doubt about that. Procal was very high. She was hypotensive. But many patients with, like you have patients, pregnancy-induced complement-mediated TMA, many of them just after surgery or delivery become suddenly hypotensive. TLC counts are high. They have no infection. Within 12 hours of surgery itself, they have, and many patients with TMA have high TLC count. So I will not necessarily consider infection always as a just because the TLC counts are high, but because of the process of TMA itself, sometimes leukocytosis. At least that's what we have seen in larger number of patients with TMA. The leukocyte counts may be present, may be high even in absence of. But this patient, I would agree that this patient had probably, although they couldn't find out the cause of infection, and whether the question raised is whether one would give eculizumab in these kind of conditions. And I think over the years, Ranjit talked about it, but I think at this point of time, I think anywhere else in the world, since eculizumab is available, people will use eculizumab as early as possible. They will not wait, even in adults. I don't think anybody would wait at this point of time for a conclusive diagnosis. With a suspicion, clinical diagnosis of TMA, most patients around in the world will be treated with eculizumab in these kind of conditions. It is true that in our condition, obviously, we might have to resort to plasma exchange in majority of our patients till we acquire eculizumab because it's not available. But now with the availability of eculizumab in the market, it's quite likely that we should get used to the idea that we should offer it to patients who might be able to afford it. There may be some patients who, if we don't know that this can be used as early, we might be able to save many patients from acute cortical necrosis. And I had one experience recently. This is post-transplant, ABO-incompatible transplant. Our previous antibody-mediated rejections in the ABO-incompatible transplants have resulted in 6 nephrectomies. All 6 had to be nephrectomized to save these patients. But this time, we were able to use eculizumab and we were able to prevent development of acute cortical necrosis and infection. So this is important that we should sort of realize that this might be available and some patients might be able to afford it. And therefore, this is an option which can be given occasionally to these patients. And eculizumab is now going to be available. I think it's already in the market. And it might be available now for the hospitals to be kept in the hospital for urgent use in many of these situations.
I think, Professor Anuradha, 2 questions. One is, what do you think is the final diagnosis? It is the sepsis which caused the complement activation. Was it the second hit? And complement, the analysis did not reveal any abnormality. So what do you think could be the cause in this patient?
Although the complement workup, they have not done, they have done only the next generation sequencing.
Yeah.
So even if the report is negative, we cannot rule out that there is an underlying mutation. Uh, uh, but there is also an evidence definitely there is sepsis, which could have been a trigger, which could have been a second, that's a second hit, which could have unmasked the complement abnormality, and the patient has presented with a complement or an atypical HUS. Whether it is just a congenital probably with a trigger due to a sepsis. Sepsis most
Any guess if the complement analysis is negative and the patient recovered, whatever the initial damage had occurred, but gradually, do you think plasma exchange was useful?
if even if it is due to an autoantibodies due to
Yeah,
a
if it is due to
sepsis,
anti-H antibody,
yes, even then plasma exchange could
is
be
useful.
beneficial.
Yes.
Yeah, then it is useful.
Yes,
Whether it is streptococcal pneumonia or whether it is any of these, then of course
would
it is
still be
useful.
useful. And of course, I would also like to congratulate the team for Dr. Jairam and his team for working up this case. But for the student, there are now, as we understand that this disease more and more, there are a lot of many more investigational treatment options which are being studied. Some of them are in the phase 3 trial, like narsoplimab. Now we are talking about eculizumab. Um, Recombinant Adam TS13 is also, that also is in a phase 3 trial. So probably it is a future is seems more promising for management of atypical HUS, which at one point when I was doing my MD, whenever we see such cases, we would just write them off. But that may not be the case now. We have more treatment options, and even if there is transplant options are open now, you can have prophylactic eculizumab is available, as Dr. Vijay Kher has said, and in most of these cases, eculizumab, if available, they can be safely be worked up for transplant, and transplant also seems feasible for these patients.
Yeah. There are some questions from audience that if you are going to transplant, let's say this patient who has a complement deficiency, should we avoid CNI altogether? I possibly will not. Your comment was a case. Dr.
Yes, no. I think there is evidence that people have used the same immunosuppression in patients in these kind of events. Just because infection triggered, it's not necessary that drugs might also trigger it the same way. So there may be.
Tacrolimus is better than using
I think that's currently the drug of choice is tacrolimus, but I think people have described TMA related to tacrolimus also.
Very many. I have
calcineurin,
four of them.
It has been described, but I think I wouldn't. The question which I have is also that if she was to be transplanted, now how would one, even if we haven't demonstrated any complement genetic abnormality, we also don't have, we might do MLP, but because we will have to complete the genetic analysis for complement deficiencies. And even if that is negative, this still I would feel that the choice would be using eculizumab as a prophylaxis.
Yes.
And I have two patients in whom we have transplanted using eculizumab as a prophylaxis in some of these patients. So I think these are methods that we are likely to get successful doing transplantation in some of these patients. Definitely.
Yeah. Professor Jairam, any comments? First, you must accept compliments from all the members that it is beautifully worked up. That is what is required. And given the circumstances in which the patient is reported to you, possibly on day 5 or day 6, already the damage has already occurred. And that is the time, whatever possible recovery, you can't get away from. If the procal is more than 200, TLC is high, you can't get away from giving antibiotic. Possibly that is no choice. Your comments. Any final comments?
final comments is that I have learned a lot about HUS from each of the esteemed members on the panel here. Probably will handle maybe best time. And only one comment to Dr. Kher, that we are one of the best centers in the world, sir. You posed the question, if you were in the best center of the world, how would you handle it?
Yeah, no, you are. I'm saying that availability. Availability, yes. Availability in the country is poor, and that's the problem. So it's not.
Ranjith is working in the office of
my own knowledge. One question from the esteemed faculty: whether it is hereditary or acquired complement-mediated TMA, what is the role of a C5, that is crovalimab, or factor B, which is iptacopan? Anybody? Because if most of these are complement-mediated TMAs, so what is the role of these drugs?
C5 blockers, you said?
Yes.
Yeah, eculizumab is a C5 blocker. Iptacopan is an earlier, it's factor B inhibitor. So depending on as drugs become available, specific drugs become available on these, so you might be able to, you might be able to target specific genetic defects with specific drugs, and it's quite possible that you would be able to do that now that these drugs have started becoming available. And I'm sure more and more experience of using selective drugs for selective genetic deficiencies at this point of time. Although the final common pathway is C5, 9, but if you can block, because there is a genetic defect in an earlier part of the chain, then I think you might have specific drugs, iptacopan or other drugs. Ravulizumab is a similar kind of a drug to eculizumab. It's a longer acting drug where you don't have to give it every month or every 2 weeks. But you might give it every 2 months or so.
Every 2
on a long term.
More convenient.
Yes, more convenient.
I think we are finishing exactly. It is 8 o'clock. We are finishing one. Any final comment, Professor Ranjith? You are in office of DGAFMS now. Is eculizumab now getting available in Army?
Yes, sir. We have a patient with postpartum HUS, atypical HUS, on dialysis at base hospital. She has been started on eculizumab.
For how much you are buying it now?
70,000 for, that's how I found the cost of it. 70,000 for 300 milligrams. Sir.
For 300. That means you have to give 90,000 to 1 lakh per week.
Yes, sir.
So that means initial 3 months if you are giving. So 12 weeks, you are spending just around 12 lakhs.
Sir.
No. Initial 300 milligrams, you said 70,000. So
900 milligrams
will be
2.1 lakhs per week.
2 lakhs. 2 lakhs. 2 lakhs. So 12 weeks, you are spending around 24, 25 lakhs.
Yes.
And then if the response is there, then these days people start thinking of taper, or there is a consideration for stopping
the
also.
Taper is only after you have given 4 to 5 weeks of alternate fortnightly therapies. Not before that.
Yeah. So it's not too expensive. Armed forces can always.
Yes, the cost. See,
that's a good news.
If you look at the costs which were when you were buying it from the market, which was the grey market, 300 milligram was costing 1,50,000 rupees or so. So this was about half the price now.
Yes.
So when it is now being marketed by AstraZeneca, is 70,000 rupees for 300 milligrams.
Yeah. There is some question from audience. Last question. I think I don't have answer for that. He says if I've taken the question correctly, if you are giving plasma exchange, if you are giving eculizumab, even then the platelets keep falling. What can be done? So logically,
very hard.
It's very hard to fathom what can happen because there is nothing more available at the moment for that.
In the country, so yes.
Yeah, in the country. I think if not before handing over to Professor Kher, I personally thank Professor Jairam and General Ranjith Nair. Both of them have been my old friends and old colleagues.
And students.
For
Yes, students, sir. We are your old students.
For wonderful presentation and wonderful bringing about the discussion also. Professor Kher, sir, for your final comments.
No, I think I would agree with you that this has been a very learning kind of case presentation, and these cases are, although you are seeing now more commonly in these patients, and we are now able to investigate many of these patients, and therefore it's likely that now with the availability of eculizumab, you should be able to treat some of these patients, if not all of the patients. And there is a government scheme also available. The rare disease eculizumab is also available as a part of the government gesture for rare diseases, and government provides 50 lakhs of rupees to a patient. Although this will take some time to get the drug available to the patient, it might not be the best thing, that because these illnesses require drugs to be available very, very quickly. And although with the availability in the government system, it might take longer time, but these are available, and I'm sure we are going to probably become better and better in utilizing these drugs for some of our patients, and we might be seeing better outcomes in these patients, because the outcomes in many of these patients have not been that good because of the non-availability of the drug. But I think compliment and kudos to the team, and Sooraj did very well in presenting this patient, and I must thank Dr. Ranjith and Jairam, as well as Anuradha, Professor Anuradha, for being there to give the expert advice. And with this, I must also thank Steadfast for providing us this opportunity to conduct these sessions, and it's been an extremely good educational kind of service that they've been helping us to do. And I, on behalf of General Verma, would like to thank you for being here on this evening, and we come in next 2 weeks again with another case discussion. Thank you very much. Good night. Bye-bye.
Good night.
Good night, sir. And Sooraj should be complimented for a good presentation, sir.
Yes,
he defended his case well.
Student did well. As a second-year student, I think
did very well.
The teaching of his teacher, Professor Jairam. Yeah.
Yes. Very well. Thank you. Bye-bye.
Thank you very much, sir.
Bye-bye.
Good night, sir.
Okay, bye.
Thank you, everyone. Thank you, our distinguished panel, for such a comprehensive session. Thank you and good evening.
Thank you, Praneeth. Thank you.